Hi everyone, welcome back to Journal Club. Hope everyone's doing well on this Monday and that you survived the polar vortex last week, which was crazy. I'm in Illinois, so it hit us really hard. So tonight I misspoke in the email earlier today. I think I just posted the wrong information. So this week we are actually going to be covering transgender psychiatry with Dr. Max Lichtenstein, and he is now, so I'm just adding him. And oh, hi there.
Hey,
How's it going?
going well. How are you?
Good, good. So I was just saying that actually I was just starting to introduce you, and thank you for joining us tonight. Uh, we will be hosting Dr. Lichtenstein both today and Wednesday on two different articles, so thanks for that. I did want to read his bio just to let you guys know a little bit about him. Dr. Max Lichtenstein attended medical school at St. George's University, psychiatry residency at SUNY Downstate, and completed a consultation liaison fellowship at Icahn School of Medicine in Mount Sinai. He's currently an assistant professor there, and he's been working at the Center for Transgender Medicine and Surgery for the last 2 years as a psychiatrist. His research is currently in examining factors that postpone or prevent transgender individuals for accessing gender-affirming surgeries. He says that he loves just about everything about psychiatry, real connections with patients, making people's lives matter, and great coworkers and team members. He says that there's never a dull moment in his work, and as an early career psychiatrist, Psychiatry Network gives him the access to knowledgeable and experienced psychiatrists in all different areas. The discussions are great, studies posted are interesting, and there's often a lot to laugh at too. So thank you for saying that. And yeah,
No, it's a
welcome.
great group.
And why don't you start out by telling us
Yeah.
which article you're going to be presenting?
So there's two articles in this sort of like mini series on transgender mental health. So the first one is
Mm-hmm.
called Transgender Research in the 21st Century, a selective critical review from a neurocognitive perspective. And it is a review type article by three Danish writers. So the first person, I couldn't find much about him. He's a psychologist. The second one is an MD, PhD,
Mm-hmm.
Greet de Cooper, who writes a lot of in the European journals about transgender medicine. She's on, I believe, the work group in the ICD-11 to
Okay.
determine where gender dysphoria is going to fall in the ICD-11. And then Guy Shojen, who I also don't know much about, but appears to be an endocrinologist who is very involved in transgender care. And because of that sort of perspective, a lot of the studies in this review are sort of European-based. There are certainly some great American studies in here, but I'll go into why that is not so great in some ways too in a little bit. So I think the first thing to do is just go over some basic terms, just that people are familiar with in this article. So because when you're dealing with transgender health in general, knowing a little bit about gender helps. So when I say gender identity is one's internal sense of one's own gender. The sex assigned at birth, it used to be called biological sex, is the sex that's assigned by usually a doctor at birth, usually male or female, though intersex folks are certainly worthy of their own discussion, and there's a little bit of talk in intersex treatment in the next article. When we say gender dysphoria is the distress that one feels when one's gender identity does not match their sex assigned at birth. And two categories of people, so transgender people are broadly speaking someone whose gender identity does not match their gender assigned at birth, and a cisgender person. And so you can think of sort of the cis and trans bonds from like organic chemistry back in college. So the trans bonds are kind of like this, and the cis bonds are kind of like this. So the cisgender person has their gender identity matching their sex assigned at birth. Also important, gender dysphoria for American psychiatry also is a diagnosis in the DSM-5, which we don't really need to go into specifically diagnostic criteria in this. You can look it up in your nearest DSM, but involves persistent cross-gender feelings and the distress associated with those feelings. Two other terms used pretty commonly in this article is something called CSHT, or cross-sex hormone therapy. There's a lot of different terms for this. I usually use HRT, or hormone replacement therapy, but that's the term they use in this one. In transgender women, so women who were assigned sex male, it includes things like estrogen and testosterone blockers, and in transgender men, often includes testosterone. And gender-affirming surgeries can kind of be grouped into three categories. So top surgery is things like chest masculinization surgery in trans men, breast augmentation in trans women, and then bottom surgeries are vaginoplasty, orchiectomy, hysterectomy, or phalloplasty, or metoidioplasty. And then we also have like the other category of things like facial feminization. Okay. And this journal came out in 2017, December of 2017, so it's fairly recent. And when talking about the European focus, so right now there is no gender dysphoria category in the ICD over in Europe. It's a fairly new diagnosis. The ICD hasn't really caught up quite yet. We tend to use equivalent terms that are in there, but a lot of these European studies still use gender identity disorder, which is from the DSM-4, which has much more stringent criteria, which means that there's a lot more selection bias in these studies. And it tends to underestimate the number of trans people and also only get you very specific subsections of the transgender population, or people who are really seeking medical transition. Okay, and there's also some studies were a little bit old, and I'll get into one in particular that kind of made my eyes cross. Just was very confusing to read and using terms we don't use much anymore. Okay, so the first part of the article talks about epidemiology, and they mentioned sampling bias. And as I mentioned, sampling bias is a pretty big problem in trans medicine in general. It's like, who do we count in these studies as transgender? So there's usually an underestimation of the transgender population in most of these studies. And they acknowledge that. The one study they give for European population estimates 4.6 trans people per 100,000. That is, I would say, a gross underestimation, because most of the studies I've seen recently are close to the other studies that they mentioned, which is about 0.6% of the population is presumed to be transgender. There's little differences between trans men and trans women. Usually trans women wind up a little bit higher in population percentage than trans men. Also, in all of these studies, whether they're underestimating or overestimating, are showing an increase in people identifying as transgender in the last 2 decades. And it's been a pretty consistent finding. And that's most likely due to a relaxation of laws about things like cross-dressing and morality laws, as well as a more welcoming and open societies, particularly in the West. There does not appear to be any sort of issues related to like steroids or hormones in food, or any sort of genetic changes that are causing this increase. And then they go on to talk a little bit about mental health in the transgender population. They in one European study where they go over 4 countries, which I think were Germany and I think some Nordic countries. They're using the gender identity disorder diagnosis. So this is a more narrow subsection of the trans population. They found that 35% meet criteria for an Axis 1 diagnosis. Of those same group of people, 27%, that was an affective diagnosis, mostly depression. 17% was an anxiety disorder diagnosis with PTSD and GAD, panic disorder being up there. The lifetime prevalence of Axis 1 disorders was 70%, so quite high. affective disorders being 60%, and anxiety disorders at 28%. Axis 2 diagnoses were up 15% in lifetime prevalence, which is on the high side. I think we don't have a lot of great data in personality disorders in trans folks. I think personality disorders in general don't have a lot of great data, but that's on the high side of what I've seen. Substance use disorders about 16%, eating disorders about 2% lifetime prevalence, and psychotic disorders at about 1%, which is also about what I've seen from other studies. Another thing that they mentioned that's gotten a lot of sort of recent press, particularly in child and adolescent psychiatry, is an increased rate of autistic traits, not necessarily autistic spectrum disorder, but autistic traits in trans kids and also trans adults. And that seems to be, it's still kind of early to say for sure what if that's going to persist, but there's been a number of like pretty well done studies that have shown this. Another thing that they mentioned, which was a really big point in the study that came out in 2015, was a really high rate of suicide and suicide attempt in the trans population. So a lifetime rate, depending on what study you look at, between 30 and 81% of trans people have a lifetime suicide attempt. It's extremely high. And this was done in US studies that they reviewed, and that's compared to a 4.6% in the general population. So just astronomically high. The US Transgender Discrimination Survey, which is a survey I use for a lot of my data, the rate was 41%. Things like maltreatment, victimization, depression, substance use, being young, particularly age in early 20s, are all risk factors for suicide in the trans population. And mortality in general is higher in particularly in trans women, and that comes from not only suicide but also increased rates of HIV, neoplasm, and heart and lung disease. The rates for, and unfortunately the studies in trans men are less good and less frequent, and there really was no shown to increase mortality for trans men. There's also an increased rate of non-suicidal self-injury. So 38% of trans people have a lifetime rate of this. And about 57.7% of trans men, about 60% of trans men. Sure. So maltreatment, so things like abuse, gender victimization.
Sorry, let me just.
Oh.
No. I was just going to say for any, because later the comments won't show up. So there was just a question, if you could please repeat the suicide risk factors. Sorry to interrupt.
Sure. So the this risk factors, in particular, maltreatment. So things like trauma, losing one's housing when you're young, or something called gender victimization, which are things like discriminatory practices in housing, at work, being fired for your job for being transgender, depression, so diagnosis of major depressive disorder, substance use kind of goes along with that, as well as young age, so age early 20s, so 20 to 22 tends to be the highest rate of suicide. And yeah, so those are the big ones. So good news, transition helps all of this. So transition, including cross-sex hormone therapy, surgeries, and social transition, or living as one's gender identity. Actually, the rates of mental illness and Axis 1 disorders, from Axis days, approach normal population levels in folks who have transitioned. Things like depression, anxiety, psychosis, global functioning, all improve after 12 months on cross-sex hormone therapy. And things like depression, body uneasiness, dysphoria about one's body, as well as what's called social dysphoria, or dysphoria about one's being identified as the wrong gender, and psychopathology in general, measured by, in this case, a 90 symptom checklist, improved over 2 years on HRT, so they continue to improve. So things that can impact trans people's lives, certainly things like social, environmental, and individual factors. Um, so what was I going to do next for this one? So there was a large EU study looking at gay, lesbian, bisexual, and transgender people. And they found that life satisfaction rates in Europe, it was several, I think, tens of thousands people study, found that life satisfaction for transgender people was lower than lesbian, gay, and bisexual people. 46% of trans people were discriminated against or harassed for being transgender in the last year, and 30% while looking for a job, and 23% while at work. In a study done in the United States looking at queer youth, like LGBT youth, showed that discrimination and poor social support, discrimination at school, I should say, and poor social support were all associated with suicidal ideation and self-harm. So this is the really strange study from 2005. The data was 2003. So I was reading it, and they kept using these words like androphile and gynophile that I hadn't really heard before. So androphile is just a person who loves men. So and then a gynophile is a person who loves women. And I think that was, and actually I think that study did that really well as a way to sort of avoid confusion with words like straight and gay. The study itself, I went through and read. I think what we would say misgenders people now. So it found that homosexual trans people have a more difficult time. We would consider them heterosexual trans people now. So trans women who are attracted to men, they considered homosexual. But in this case, they found that they also did something that kind of frustrates me in these type of studies, where they grouped all of they basically did straight people and then not straight people. So they kind of miss a lot in that. So they put asexual people over there, they put bisexual people over there. So not the greatest study, but a very interesting study because they took tons of measurements, like everything from like facial hair growth to body mass index to fat distribution to like changes on hormone therapy in a ton of people. And they found that what we consider heterosexual, so androphile or male-loving trans women, and gynophile, so female-loving trans men, had earlier age onset of gender dysphoria, and also androphilic trans women had more genital dysphoria, so they were more likely to seek vaginoplasty or bottom surgeries. And androphilic trans men also had more psychopathology in general. So gay trans men. And that can be seen as maybe like a compound of stigma as well. So then they kind of move on to like the meat of this study and how this study or this review is sort of differs from a lot of the other reviews on transgender medicine, where they start to talk about structural and what we know about sort of the brains of trans folks. And I think the big caveat that I want to make very clear is that there is no clear biological marker or cause of being transgender that has not been identified. And most studies in this category attempt to compare the brains of trans folks to the brains of cis folks. And again, that presents another problem with selection bias. So whose brains do we compare? Do we compare trans folks who are pre-treatment with HRT, or do we compare trans folks who are post-treatment with HRT? Do we include both? What about surgery? The answer is, right now, we include a very small number of trans people. Most of these studies have ends of like 5, or sometimes I think as high as in maybe the dozens. But there are some very interesting results that have come out, like preliminary. So in structural neuroanatomy and resting state, the first section, there's a lot of contradictory information. So there's some studies that show nothing, some studies that show one thing or the opposite. But in one study of 24 untreated, so trans folks who weren't on hormone therapy, brain volume and gray matter was similar to the sex assigned at birth. So transgender women's brain volume and gray matter distribution looked similar to cisgender men's. There's a lot of mixed results when looking at things like the corpus callosum or the putamen or various other individual structures within the brain. One study that's very often cited in the literature is a study that looked at the hypothalamic uncinate nucleus. This is like not my big area of expertise, neuroanatomy, but it looked at 42 post-mortem trans women and found that the staining of these cells resembled cis women much more closely than it resembled cisgendered men. And this is not related to cross-sex hormone therapy, or as they so postulate, because there were no change, and they also stained the brains of castrated cisgender men, and these much more closely resembled other cisgender men. So looking at white matter, there's generally very few studies on this. The one study they did look at in this review determined like an intermediate phenotype. They use something called 3T diffusion tensor imaging, which I'm not 100% sure I know what good studies in that would look like, but they looked at diffusivity in the white matter, and they found basically intermediate phenotypes that were one way and then completely the opposite. So in one study, it went sort of cis women had the highest diffusivity, then trans men, then trans women, and then cis men. And the other study showed the complete opposite, where it was cis men, then trans women, then trans men, then cis women. So there's some sort of maybe intermediate state that trans brains fall into. Cross-sex and most of the studies, I should say, focused on pre-treatment trans folks. But one of the studies they looked at cross-sex hormone therapy treated trans women. And they found the hypothalamus tends to approach cis women's size with treatment. And there's an increase in size of the hypothalamus in trans men with treatment. And as I said before, most of these neuroanatomy studies are limited by low number of subjects and absence of control data, or controls, and no pre-treatment data. So either just kind of grabbing people from a select moment in time. Overall, and this is a statement made in the review, it says, overall, they appear to show an intermediate phenotype in transgender people that shifts further towards experienced gender with cross-sex hormone therapy. I think that's a bit of a leap from the data that they've presented. I would say there's a couple of studies in there that show an intermediate phenotype, and a couple of studies that show a shift, but also there's a number of studies that they presented that show that these changes are present without treatment, including the most well-cited study, which is the study of the postmortem study of with the staining. So the functional neuroanatomy section had another couple pretty interesting studies in it. So one looked at the bed nuclei of the stria terminalis, which is a structure that connects to other limbic structures like the amygdala and hippocampus, and plays a central role in hormone signaling. And it's also and other sex-differentiated behavior, and it's somewhat sexually dimorphic in humans. And they looked at how it responds to two different pheromones, that being androstenedione and estradiol. I've never heard of these before, but there are pheromones which are active in the hypothalamus. And the brains of cisgender men and cisgender women, when compared, react differently to these hormones. And in this one study, they showed that transgender react to the andro hormone more similarly to cis women than to cis men. And when they did the same study in kids and teens, they found that the differences don't start to appear until puberty, which is also pretty interesting, because I think things like pheromone and olfaction is not something that you can think about, is not going to be really societally controlled as much as many of these other sort of studies that they're doing in functional neuroanatomy, like the next one, which they do on voice. So they looked at male versus female vocal recognition. So cis men and cis women have different reaction times to identifying whether a voice was masculine or feminine, or from a man or from a woman. Trans women were intermediate and resembled cis women more often on the tasks of vocal recognition. In sort of male typical and female typical tasks. So in FMR, or in functional neuroanatomy, mental rotation is typically seen as a male preferred task. So basically taking an object and rotating it in your mind. I had to sort of look up what these studies look like, and basically they're two objects and they're kind of rotated differently, and you have to decide whether or not they're the same object or not. And it appears to favor men over women. So trans women showed an intermediate activity somewhere between cis men and cis women. And trans men showed no difference compared to cis women. Verbal fluency or word production. So these are studies these are tests that you can do like at the bedside on CL when someone's had a stroke, like name how many animals, and you can in a minute, or name how many words that start with F in a minute. And they're said to favor women over men. And this study was done in teens and kids. And trans girls outperformed both cis boys and cis girls, and then repeated in adults. Trans women outperformed both cis men and cis women. So that's kind of a strange result. And other studies had very small sample sizes and really didn't show any other statistical significance. And when it comes to things like neuroaffective research, which is a really fascinating area of functional neuroanatomy, there is no research whatsoever. This review didn't uncover any studies on neuroaffective research. And to kind of conclude things, we kind of went over epidemiology. We went over some particular risk factors for the trans community, suicide being one of the really big ones. I think if anyone had, any group of people had that high rate of suicide, we would really want to make sure that we were doing our suicide risk assessments when we meet them the first time, talking about suicide safety plans and screening for risk assessment. Imagine if like veterans, for instance, had a 40% rate of suicide in lifetime. We'd really be on that. And then also there's a bunch of these very interesting preliminary studies, but there's still no real clear biological marker or cause of being transgender. Alrighty, and then they kind of, they looked at a couple of future perspectives. So one of the things that they kind of emphasize over and over is that there really needs to be these larger multi-center studies to get the type of power that we'll need to really identify if there are any differences to brain anatomy. And also better control for social differences between countries, which appears to affect psychopathology. Certainly being in a very oppressive country, like for instance, Chechnya or Jamaica, would be a very difficult place to live and certainly cause a lot more psychopathology than living in somewhere that maybe has really progressive laws like Malta or the Netherlands. We need to improve our selection bias. So we right now are doing a lot of, because most of these researchers work in gender clinics, we're kind of grabbing the people that are like right next to us. So we're grabbing people who are seeking medical transition, like hormones and surgery, and we're not really sampling the larger trans population, which don't necessarily always need to have medical transition or want to have medical transition. And then things like more longitudinal research, so tracking folks for longer periods of time. Okay, and questions or anything else?
There was one question, let me pull it up, where I'm trying to, it was a child and adolescent psychiatrist asking if there's any resources for adolescents online or support or resources for online therapy, since they are sparse for therapy in her area for transgender patients.
So I'm not a child adolescent psychiatrist. I'm not sure about like national organizations. I know a lot of resources here in New York City. Uh, where's this person from?
This is Missy Reen. She could respond and tell us. I think she's still watching. And then she had a follow-up question that I don't know if you want to address or not.
Mm-hmm.
I'm not sure where she's from,
Okay.
but offhand, you're not aware
I would have to look something up. I
if
don't know
that's not
off the
your
top of my
area.
head. Yeah, specifically for
Okay.
kids, I should
Oh,
say.
she's in New York,
Oh,
actually.
she's in New York. Okay,
Yeah,
so
yeah.
New York, we have, let's see, and not, I'm guessing not New York City, because we have a number of programs here.
Upstate, yeah.
Oh yeah, I just did let me, there it is. I just did a presentation for folks who were asking about some resources for teens. So,
Okay.
um, I
And
don't
then
think
while
there was
you're
any of
looking
these are
that up, somebody
national.
else said that they think in Los Angeles there is a transgender research center.
Yes, there is. Most major cities have some sort of program. The ones I know of are like the Mazzoni Center in Philadelphia. We've got a number here in New York City. Kellen Lord is the largest. They definitely have a
Mm.
program for kids. And Kellen Lord also has stuff like summer camp, which is a really cool program where
Hmm.
trans and queer kids in general can kind of go to summer camp with other uh, um, the Ackerman Institute is another one that I think do they do telepsych there? I think they may. I'm not 100%, but they work with kids. So that's the Ackerman. Oh, my cat is coming from my phone. Uh, and and whoa, kitty. The also the Ali Forney Center, and this is more. The Ali Forney Center is uh, a a drop-in center and a place for homeless trans youth or homeless queer youth, and is a
Okay.
great resource if this person really does get in a lot of trouble with that. Do, do, do.
And then
Yeah,
somebody
so I'm
mentioned happyhippies.org for Miley Cyrus's online resource.
okay.
Have you heard of that?
I haven't heard of it. I'll take a look at it. Uh,
Okay.
Miley Cyrus has been generally a big proponent of trans folks, so
Hmm.
uh, I believe it.
Okay.
Okay.
And there's another question that is very specific, so I'm not sure, but she said that she sees quite a few transgender slash gender identity disorder patients adolescents who have also autistic traits, borderline to low IQ, with comorbid depression or anxiety. Would you delay treatment compared to other transgender adolescents to process their course of transition through therapy before considering HRT therapy?
So I guess it kind of means what you talk about, like delayed treatment. So in kids, there really isn't much to
Hmm.
treat. So if someone is below
Hmm.
like 10 or stage 2, that's even before you would consider stuff like hormone blockers. Um, and this is kind of out of the scope of this article, but um, uh,
Hmm.
the general recommendation for dealing with kids is a concept called follow the child, basically, where you go with the kid where they want to go with their gender without sort of determining or
Hmm.
having any prejudgment about whether or not they are transgender or not. So just letting the child
Hmm.
explore their gender. If they wind up continuing to have a lot of gender dysphoria in their teens, and by the time they're in their late teens, like they're 16, 17, that dysphoria is unlikely to remit. If they're in their
Hmm.
early teens, there can be kind of some fluctuation. And in kids, we don't do, unless it's something like where there's a very clear, a very clear diagnosis where the person has great social
Hmm.
support. Someone like Jazz Jennings, for instance, we really don't do surgery on folks under 18.
Hmm.
Um, Hormone
Okay.
therapy is something to consider if first of all, if the parents are on board. I think almost everywhere the parents have to be on board. But also, hormone therapy is generally reversible. There's a couple of things that aren't voice changes in transgender, in transmasculine people. So if you take testosterone, your voice gets lower. That doesn't change. And then some breast growth is not reversible, but oftentimes it is completely reversible. So it's actually a pretty low risk thing for hormones. And if it really helps with their dysphoria and can also help with things like agitation and folks who have, decreased ability to self-soothe.
Well, great. Actually, that answered the last question that was posted. You essentially posted or answered that question, so I won't repeat it. I think that's all we have. And she said, thank you. Very good point. Her question was for 15 to 18-year-olds. So thanks for all that information. I feel like I have listened to a number of presentations and have had a few patients. I work at the VA, and I still feel like I learned a lot. So thanks for all the background information that you added. And you guys, as I was mentioning at the beginning, my email was kind of I sent the wrong information in the email. So this Wednesday, Dr. Lichtenstein will be joining us again and covering a different article called, let me just pull it up, Transgender People, Health at the Margins of Society, which he says that he is very familiar with. So that's great. So thank you.
It's a great article. Yep. Okay. Thanks. See you on Wednesday.
Okay. All right. See you guys. Bye.